This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.
Hello, my name is Dr. Rob Page and welcome to Doc Talk. Doc Talk is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients that are helpful in terms of how they approach their own health care and making their health care decisions. And with that in mind, I have with me today Dr. Matt Mancini. Dr. Mancini is a general surgeon who works with university surgeons at University of Tennessee Knoxville Hospital. Mm-hmm. And you are here today to talk to us about gastroparesis.
That's correct.
So let's start off with a general question for patients. What is gastroparesis?
Well, by definition, it's kind of a paralysis of the stomach. It's an uncommon condition, although with the rise in diabetes, which can affect the nerves that cause the stomach to not empty correctly. So it's basically a pretty disabling disease process where patients really struggle with nausea, lots of vomiting episodes, and really unable to tolerate a regular diet.
Gotcha. So if I'm a patient, what sort of symptoms would I have? Are these all typically diabetic patients? Is there a more common type of patient? And what sort of symptoms, if I'm having trouble with nausea, vomiting, what signifies it as being gastroparesis as opposed to maybe something else?
Typically, the symptoms are similar to other upper abdominal complaints. So people might think they're having, indigestion or heartburn, a lot of nausea, and typically they usually get diagnosed because they've worked with either their primary care doctor or even their gastroenterologist to do a pretty extensive workup if they are very nauseous, lots of sick time, lots of vomiting episodes, struggling to keep on their weight. And about 55 to 60% of them actually are caused by what we say idiopathic, which means we don't know what caused it. Could it be a viral illness? Could it be a surgery that they had on their upper stomach? But most of them, we don't really ever find out what the root cause of it is.
Gotcha. So what sort of studies do they do in terms of diagnosing gastroparesis?
So usually the best test is what's called a gastric emptying test. And that's a nuclear medicine test where they make a tracer called technetium, which is something that they can see with a special scanner. And they mix it up in some scrambled eggs. That's your solid phase, and then they would give you some liquid with that technetium based in it. And then they can actually measure how much of that radioactivity stays in the stomach for 90 minutes and up to 4 hours. So they'll basically look at how the stomach empties, which a normal stomach should empty within 2 hours. So when food is staying in the stomach for 3 and 4 hours, then they can have a lot of upset stomach, nausea, bloating, belching, that sort of thing.
So this is not an invasive test. Essentially, it used to be a test that I would just show up and have to eat scrambled eggs, and
Yep.
you would take some X-rays
Yep.
maybe and figure out what was going on with me. So I've had this. So I've been worked up. Oh, I'm sorry.
Well, sorry, but a lot of times a gastroenterologist will make the diagnosis just by doing an endoscopy and then seeing food still in the stomach. So
Gotcha.
normally when you would have that procedure, you would not eat or drink anything for a 6-hour time period.
Right.
Patients with gastroparesis won't eat for 12 hours, and there still may be some residual, food left in there.
So intrinsically, the stomach does not. What we ideally want to see is a stomach that holds food in it for a certain amount of time, undergoes digestion, and then will move it. They'll move the food into the other parts of the GI system in a fairly, not necessarily rapid, but routine fashion. And patients with gastroparesis, the food just never really goes anywhere or goes very slowly.
Correct.
And we could have been diagnosed by our gastroenterologist if we've had maybe an upper GI or an upper endoscopy, or perhaps we have the symptoms. We've had nausea, and we've had the gastric emptying study, which has shown that our stomach exit slowly. What sort of options are available to us?
Well, we start trying to do dietary changes. Obviously, if we can avoid medications, if we can avoid a surgery, we're always going to do, adaptive medical therapies, which may just be changing how they eat, eating smaller, portion sizes, not eating raw or uncooked vegetables, things that typically would go slower. So unfortunately, those are healthy things. So a lot of our patients kind of suffer because they have to eat higher processed foods and aren't able to really get that healthy, all four food groups in. But when those dietary changes don't relieve their symptoms, there aren't really many medications out there that are safe. There used to be some that have been now recalled from the FDA, but Reglan is a old-timey prokinetic drug that has a black box warning on it.
And when you say prokinetic, you mean?
To help the stomach churn.
Okay.
Yeah, to help kind of move the food through the stomach.
Gotcha.
And Reglan has a lot of side effects. And so there's a black box warning that you really can only be on it for a certain amount of time. And
Gotcha.
gastroparesis doesn't come and go. Once you have that, it's a chronic problem. There are also medications called Domperidone, which is compounded, and you can't get that in the United States. So a lot of our patients have to get Canadian medications sent to them. And so there aren't really a lot of great medications. Erythromycin, an antibiotic, has prokinetic activity. But then again, if you're on an antibiotic, then you worry about yeast infections and side effects of antibiotics. So again, the medical therapies are quite limited. And I think the gastroenterologists are very frustrated by that because they say, well, I can write you this prescription, but you can only take it for a month, and then you have to take a month holiday, and this medication might cause this side effect. And so they're quite frustrated.
Yeah. So fortunately, there are there newer alternatives? Are there better alternatives that we can seek, especially, or perhaps come to you and be able to have you approach it in a better fashion? So again, GI doctors can make referrals, or primary care doctors can make referrals. But I started working with what's called enterotherapy, which is a gastric pacemaker. So it's similar to a cardiac pacemaker. Oh, wow.
It's the same battery and the same electrodes, and you have two wires, and rather than putting it into the heart, we actually implant it into the lower third of the stomach.
Oh, wow.
Now, that device has to be put in laparoscopically or minimally invasively, but it's still under FDA watch. So it's only FDA approved for compassionate use, which is a lot of medical jargon for you have to come see me to get it.
Right.
I have to submit all my patients' records to the FDA. I have to go through the IRB, which is our Institutional Review Board, every year. I have to report any side effects, complications, so that this is still something that really is only done at an academic medical center.
Right.
And so that's been a great device. I think 70 to 80% of patients that have that device see improvement in their nausea and their vomiting episodes. They're able to get back to eating more normally, which is phenomenal. And a lot of them gain weight and feel like they're not always sick at their stomach and requiring hospitalizations and IV fluids. Now, not all insurance companies cover that. Some, and I won't mention them, really feel like it's investigational and not something that is ready for primetime use. So that's an option. Another option is called a Pyloroplasty, which means we open up the lower muscle of the stomach where the stomach empties. I do that robotically, and that's been just a phenomenal procedure that can be done robotically or minimally invasively. And then the last is an endoscopic procedure, which I don't perform, but I think you met Dr. Kleppe a month or two ago, and he trained up at the University of Wisconsin and learned how to do an endoscopic myotomy that he calls the GPOP, which basically uses an endoscope to go down to where the stomach empties, and he can actually divide the muscle endoscopically, requiring no incisions. So a lot of our patients come and they say, gosh, that's so many options. You've kind of made the menu's gotten too long. But not all patients have the same insurance company,
Right.
and so we have to work with that patient and that individual policy to find out what's their best option. And sometimes it's both. A lot of our patients, we've seen the data benefit from having the endoscopic myotomy, which Dr. Kleppe can do, and then I put the gastric pacemaker in at the same time. It's an outpatient procedure. They go home the same day.
Wow.
We turn it on, and they sometimes have immediate relief.
Oh, that's incredible. So this is so you already started answering my next question. So if I'm a patient and I've been suffering with gastroparesis, and I've tried medications and I've tried all these other different routes, there are surgical options, and there are multiple surgical options, and even on occasion multiple surgical options that I can pursue at the same time. Now, talking about the pacemaker, how long have you been doing that? You mentioned it was somewhat investigational, but this is not like an experimental procedure
Correct.
or anything of that sort.
No, I think I've probably been at least 10 or 11 years that I've been working with Medtronic and enterotherapy. And I kind of wish, the only thing I wish is that, with evolution, you would think that these batteries would be rechargeable because depending on the settings, and I can adjust the settings in the office, I have a little computer that adjusts the settings, how long it's on, how much impulse I'm giving them, how frequently the impulses are, may change the battery life from 7 years to 7 months.
Gotcha.
And so patients with severe gastroparesis that need a lot of stimulation, the battery may have to be rechanged, out every year or two, and that's another operation to change out the battery. So again, that's why if we can do an endoscopic myotomy and get a little bit more bang out of the battery, then that sometimes will cut down the cost of and the number of times they would have to have their battery.
But even having the battery replaced, that would be done endoscopically, minimally invasive. Something that we would basically be able to do as an outpatient.
Yes. The battery change is just, it's underneath the skin, so we have to just open up the skin and then change out.
So you can do that in
battery.
the office, essentially.
I have to do it in an operating room.
Okay.
Yeah. It's something that has to be extremely, extremely sterile. If these devices get any infection, then you'll lose the device.
So in the operating room, mainly for the sterile setting,
Yes.
and not because it takes any longer, or because we'd have to stay in the hospital any longer, or something like that.
No, the procedure is 5 to 10 minutes, and a lot of times the anesthesiologist can do this with just conscious sedation.
Oh, that's great. So, you've taught us a lot about gastroparesis, and you've taught us about basically I think some of the patients who aren't aware that they have this. They certainly would want to approach their primary care doctor and ask them maybe to do additional studies and find out if that's exactly what they have, if they're having this nausea. And of course, you've also talked about, there are other sources that maybe could be causing this, so it's not necessarily gastroparesis. And you've talked to us about the surgical procedures that we can that we can pursue as a patient in your at your practice, and basically be able to improve our quality of life.
Mm-hmm. Absolutely.
So what I'd like for you to do is, so now that we know that you're available, we know that there are these multiple procedures available, how would we go about maybe finding any additional information on this if we wanted to read about it? How would we contact you or your office and be able to get in touch with you if we wanted to schedule an appointment?
It's very simple to just call our office, and our website has lots of information, and then Medtronic's and Terra Therapy, you can put in your zip code and I should pop up.
Yeah, I was going to say, now we're going to have all this information down at the bottom of the screen.
I'm the only real person in Tennessee doing it.
Oh,
so
wow.
Because you have to go through an IRB. Vanderbilt had a program. They did not continue that program. So pretty much, if you're in Tennessee, you're going to find me.
Wow, so this is real cutting edge stuff. So you're seeing patients, so not necessarily just patients from this area, but you see patients from all over the state of Tennessee.
Absolutely,
to do this protocol.
Yeah.
Well, that's incredible. And you mentioned about the success rate seems to be fairly good. And you also talked about the ability that you think maybe with a one-time procedure that you might be able to improve it somewhat, but you can actually improve it real time based upon how the patient is performing. You can change the settings. Right. You can go back in.
Yeah, I think it's hard the first few months to kind of know, because you try and I always kind of start with the lowest settings because I'm trying to preserve the battery. But if patients aren't feeling it, then you can change a lot of the settings. How long it stimulates the stomach, how long and how high the impulse is. So there's a lot of kind of playing with the gizmos, and I have a very good nurse practitioner that works with us and does a lot of the programming. And so, we're able to kind of fine tune what the patient needs.
And also, I would think that patients who have diabetes, that this would not necessarily be a disease that just sort of stays like it is, that maybe over time it may even get worse.
That's
and
correct.
You may actually have to change, maybe even do an additional procedure or continue to modify the settings on the pacemaker based upon the progress of the disease.
That's correct.
So anyway, well, excellent. Well, that is some excellent information you've given to us about I would think, not necessarily an uncommon disease, but maybe a disease that a lot of patients haven't heard about, and told us about, what therapies we have available to us in East Tennessee, in this area, that aren't available anywhere else in the state. We've given the information about how to contact you and how to get maybe additional information. Dr. Mancini, thank you so much for joining me here today and giving us information about this incredible topic. So, and with that, this brings this episode or podcast of Doc Talks to a close. Doc Talks is a podcast that is produced by the Knoxville Academy of Medicine and features its physician members giving information to patients to help them in terms of making their healthcare decisions. I'm Dr. Rob Page. Thank you so much for joining me.
This episode of Doc Talk is brought to you by First Bank. We're not just your neighborhood bank, we're your neighbors. Our local team lives up to the name, putting our customers and community first. To experience First Bank difference, stop by any of our 13 Knoxville area locations or visit firstbankonline.com. First Bank, member FDIC.